everyone. It's Dr. Cohen again, and we're going to be talking about endocrine conditions as they pertain to the athletic trainer. We'll try to focus on a couple of more high yield and practically relevant examples, and we'll start off by discussing what an endocrine organ really is and does. But essentially, these are tissues that are producing, storing, and secreting hormones into the blood. And what is a hormone? But basically, a chemical messenger that is trying to get the right message at the right time to the right tissue. And the key here is that it's secreted into the blood as opposed to neurotransmitters, which are how the nervous system communicates. The endocrine system will communicate through these chemical messengers in the blood. And very fortunate for us, these are autonomic functions, meaning these are generally functions that are not under our control. These are involuntary. So, for example, you don't have to think consciously about controlling your calcium levels in your blood, for example. And there's a really fine-tuned network of organ systems working behind the scenes on things like growth, development, metabolism, reproductive function to try to maintain homeostasis and sort of this idea of optimal, balanced function. And as we were sort of describing, these hormones can be steroid molecules, which are lipid soluble, or they could be protein or polypeptide molecules, which are water soluble. And kind of depends on where the target receptor is. For example, if it's a receptor that is on a lipid bilayer, it might be more beneficial. If it needs to get through that bilayer, that it should be a lipophilic or lipid soluble makeup. And in the blood, a lot of these chemical messengers are bound to proteins. And so it's important to note that only the free hormone, the components that are not bound up to something else, are the components that are able to exert an effect on the receptor and the target tissue. And to compare and contrast a little bit here, we were saying the endocrine functions on distant cells. For some vocabulary here, autocrine means that it's going to act on itself, which on that picture on the left there, you can see that the cell produces a signaling molecule that then interacts with the receptor on the same cell. And then you have paracrine, which is the left picture on the bottom there, where a cell creates a signaling molecule, which then goes to a neighboring cell and interacts with that neighboring cell's receptor. And then you have exocrine functions in the body as well. So this picture on the right is a acinus, which may have, for example, saliva. This might be a salivary gland, and it has a duct, and it will use that duct to move the saliva to the target tissue. And these hormones are often very tightly regulated by what's called a negative feedback loop, which is a really exciting piece of physiology that we're going to talk a little bit about shortly. So these are the major endocrine organs that are of some clinical relevance, especially to an athletic trainer. And we're going to kind of dive into each of them as much as we can here. And we'll start with the hypothalamus, which you can see sort of deep within the brain here. And it is going to be sort of like the control center. And it is the major connecting point between the central nervous system and the endocrine system. It regulates a lot of really important things like body temperature, hunger, thirst, heart rate, your mood, sex drive, sleep, and circadian rhythms. And you can see in the picture on the left there that these are all the different colored shapes are portions of the hypothalamus. And you can see that each of them is labeled for the sort of content that it's responsible for. You can see it covers a very wide, impressively wide amount of bodily functions. And the ones that we are going to focus mostly on today are its ability to produce hormones like GnRH, which is gonadotropin releasing hormone, CRH, which is corticotropin releasing hormone, and TRH, which is thyrotropin releasing hormone. And it's going to, as you can see in the picture on the right, it'll have a sort of a pituitary stalk that connects the hypothalamus to the pituitary, which is has those two vascular networks on the bottom there, and it's going to pass neurochemical impulses down to that pituitary, and it's also going to produce and transmit hormones into that pituitary, and we'll sort of take a look at that here when we talk about the pituitary gland. And so the pituitary gland is sitting in what's called the sella turcica at the base of the brain. Just for a reminder, is this gland just below the hypothalamus. And when we think about this central location, it is able to be sort of like the high-level manager, if you think about the hypothalamus as the CEO of the organization here. And the neurosecretory cells from that hypothalamus will release hormones into the portal system that you see there on that picture to get the hormones to the anterior pituitary. And then it will have other connections with the posterior pituitary. It has sort of two lobes where the hormones get transported directly via that pituitary stalk. And the hormones that we care the most about that the pituitary is responsible for are the thyroid stimulating hormone, the adrenocorticotropic hormone, the luteinizing and follicle stimulating hormones, the growth hormone and prolactin, which are coming from the anterior pituitary. And you can see that the target tissue is associated with each of those. So when the thyroid makes thyroid stimulating hormone, that hormone is going to go into the bloodstream and go to interact with the thyroid. And when adrenocorticotropic hormone gets into the bloodstream, it's going to go interact with the adrenal glands. And when LH and FSH get into the bloodstream, they go and interact with the reproductive organs and the gonads, etc. And then the posterior pituitary gland will be predominantly responsible for vasopressin, or ADH, which is called antidiuretic hormone. And that job is predominantly to maintain water balance and has a role in sort of blood pressure maintenance, and acts with the blood vessels in the kidneys to achieve that. And then oxytocin, which is going to stimulate the uterus or the breast related to lactation or contractions during labor. And this diagram here, although it looks fairly complicated, will hopefully make a lot more sense at the end of the lecture. Again, this is sort of zooming out a bit further. We started at the hypothalamus, which was the control center. Then we zoomed out to the hypothalamus and the pituitary gland, which was allowing us to see how an initial releasing hormone stimulated the release of a stimulating hormone. And then now you can see that there are several of these hormones coming from the pituitary that go and act on a target tissue to then make another hormone. So in the case of the thyroid, when the anterior pituitary makes the thyroid stimulating hormone, it goes and interacts with the thyroid, which will then make thyroid hormones, which can then have physiological effect. And when the anterior pituitary makes adrenocorticotropic hormone, it can act on the adrenal cortex to create glucocorticoids like cortisol, and that can go and have a physiologic effect, et cetera, et cetera. And so that'll take us to when these systems don't work so well, how do we describe pathology? How do we think about pathology in these different endocrine systems? So if there is an issue with the primary target organ, we call that a primary dysfunction. If there is an issue with the pituitary, we typically call that a secondary dysfunction. And then if the issue is with the hypothalamus, we call that a tertiary dysfunction. And this will make a lot more sense once you know more about how each of these target organs has a regulated feedback mechanism. But in the case of the adrenal glands here, for example, the adrenal glands make a chemical called cortisol. And in the picture on the bottom there, you see that the hypothalamus creates a corticotropin releasing hormone that goes to the pituitary. The pituitary creates adrenocorticotropin stimulating hormone, and that goes to the adrenal gland. The adrenal gland then tries to make cortisol. And in that first example where you see the lightning bolt on the adrenal gland, the decreased cortisol that this particular patient is experiencing is because of an issue with the adrenal glands. And so that would be considered a primary hypocortisolism, low cortisol because of a primary adrenal issue. And then in the second example there, you can see that again, the hypothalamus is stimulating the pituitary, and the pituitary is trying to stimulate the adrenal gland. But in that example, there's an issue with the pituitary, and the pituitary is unable to make the ACTH needed to properly stimulate the adrenal gland. And again, they end up with low cortisol levels, but you're not sure why they have low cortisol levels, so you keep looking and you discover that it's because of the pituitary. And so we would call that a secondary hypocortisolism. And then in this third example on the right there, again, the corticotropin releasing hormone effectively stimulating or attempting to stimulate the pituitary attempting to stimulate the adrenal gland. But in that example, there's an issue with the hypothalamus not being able to create the CRH, and so you then are unable to make ACTH, which is unable to stimulate the adrenal gland to make cortisol. And so this will make more sense as we learn more about these target organs. And we'll start with the thyroid gland. And the thyroid gland is important for several functions. In particular, we think about growth and metabolism. It also has a role with things like bone turnover, nerve, muscle function, digestive function, the mood, heart function, several others. But you can really think about this as being very important for growth and metabolism. And the hormones that it will produce are thyroxine, which is T4, and triiodothyronine, which is T3. This is how we sort of shorthand those names. And you can see in the picture on the right that there's this very complicated looking mechanism for how it makes thyroid hormone in the thyroid gland. But the major sort of take-home elements for when you look at this is that you can see that there is TSH on the bottom left side there, the blue rectangle, interacting with the TSH receptor on the thyroid, and that encourages the thyroid to produce this thyroglobulin and get the sodium iodine transporter, or symporter in this case, working so that you can get iodine into the part of the thyroid where you need to make the thyroid hormones, because you need iodine to make thyroid hormone. And then you can see that there are several different mechanisms that are happening, and at the end of it, you're making a T3 and a T4, which are going to get dropped into the blood supply, and then they're going to get bound up by TBG, or thyroid binding globulin. And this becomes an important thing for us to know about for when there is somebody who might have dysfunction with the thyroid and how we are going to think about it. So the picture on the right is again showing us one of these negative feedback loops where the hypothalamus creates a hormone called TRH, thyrotropin releasing hormone, and then that's going to stimulate TSH from the pituitary gland. Then the pituitary gland is going to stimulate the thyroid gland with the TSH, and the thyroid gland produces this T4 and T3. And in the peripheral tissues, some of this T4 will get converted to T3, which is the active form of the thyroid hormone, and then some of the T4 and T3 that are then in the bloodstream are going to go back and try to turn down the production of TSH from the pituitary gland and TRH from the hypothalamus. And so this is a nicely regulated system where as the T4 and T3 go up, it should appropriately decrease the amount of stimulation that's coming from up the chain from the hypothalamus and the pituitary gland. And if there is dysfunction here, you can get a few different things, but some of the more common ones would be hypothyroidism or low thyroid levels, and sometimes that's congenital. Sometimes it's because of a deficiency of iodine, as we were reading that we needed iodine to produce the thyroid hormones. Sometimes it's an autoimmune attack against the thyroid. Sometimes things like medications and surgery, especially if it's to treat an overactive thyroid, can make people have low thyroid levels. And then you can also think about hyperthyroidism, which is too much thyroid hormone in the blood. And that can be from things like tumors that secrete things like TSH or thyroid hormone. And then certain medications might cause this. And then autoimmune dysfunction, again, sometimes an autoimmune attack can actually produce a thyroid stimulating antibody as opposed to one that is going to damage the thyroid. That brings us to the parathyroid glands, which are 4 small glands behind the thyroid, and they're predominantly responsible for maintaining calcium and phosphorus levels in the body. And so they're going to act on the bones, the intestines, the kidneys, and they're going to either increase or decrease absorption or storage of these minerals and chemicals for us to have an appropriate balance between the blood and the bones. And you can see another complicated looking diagram on the right here, but essentially what it's showing is that high calcium will negatively feed back to the parathyroid glands to turn down parathyroid hormone production, and high phosphorus levels, PO4 for the phosphate, will increase the parathyroid hormone stimulation. And as you might remember from a chemistry class, the calcium phosphate will bind together, and that forms mineralized bony tissue. And some of the other important elements of this diagram are that when the PTH is released, it can go and act on the kidney to increase the amount of calcium that is coming back into the blood and decrease the amount of phosphorus that's coming back into the blood. It can go and act on the bone, which can increase osteoclast activity, which means activating the parts of the bone that break down bone, and that will help sort of release some calcium into the bloodstream. And then you see also that there's this element of how vitamin D plays into this, that when vitamin D is high, it can increase calcium and phosphorus absorption in the gut. And if vitamin D is low, then it can cause low calcium and phosphorus absorption from the gut. And so some of the areas for dysfunction here could be low parathyroid hormone or hypoparathyroidism. And sometimes that could be iatrogenic, meaning that the medical system, through diagnosis or treatment, caused the issue. So for somebody who has a thyroid issue and they have it surgically managed, or somebody who has surgery on their neck for some reason, you can end up damaging or removing these parathyroid glands, and that could make you have low parathyroid hormone. Low magnesium levels can sometimes create like a low parathyroid state, as it factors into some of these chemical equations. And then sometimes there can be hereditary syndromes that have that. And then there can be hyperparathyroidism or high parathyroid levels. And that could either be from a primary reason, meaning that the parathyroid tissue itself is hyperplastic and you have more cells, or that there's an adenoma, which is usually a benign collection of this endocrine tissue that's secreting excessive parathyroid hormone. You could also have a secondary issue, which means that it's not an issue with the primary target organ of the parathyroid, but it is an issue of something else that's interplaying with that parathyroid hormone. And one of the common examples that we see in primary care is renal failure. If somebody's kidneys don't work from, for example, diabetes or high blood pressure for many years, and their kidney is having trouble excreting phosphorus, then that phosphorus ends up floating around in the blood, binding up the calcium, and then that person has sort of this relative functional calcium deficiency, and so then that calcium, um, lack of free calcium makes it hard for the parathyroid hormone to feel like there's a homeostasis. So the parathyroid gland will make more parathyroid hormone. You could also imagine things like vitamin D deficiency, malabsorption from things like celiac disease, or if you were peeing out too much calcium, that those could all factor in, as well as medications that can do this, to making that parathyroid gland feel like it needs to work harder to get the calcium levels higher. And that can have several negative side effects, one of which that I'll mention based on this diagram is that it's going to continue to activate those osteoclasts, and it can break down bone and predispose to things like osteoporosis. Next, we'll talk about the adrenal glands, which we will break into the cortex and the medulla. Now, the medulla is not regulated by the pituitary gland, and that is the part of the adrenals that are stimulating the sympathetic ANS, the autonomic nervous system. So that's making things like epinephrine, norepinephrine. That's going to be your fight or flight response. And then one of the areas that is going to be, that we'll try to dig into a lot more in class is the cortex. And the cortex is going to have 3 distinct layers, and we think about them as salt, sugar, and sex. The salt layer is the zona glomerulosa. You do not need to know these names, by the way, but the sort of outermost rim is going to be mostly responsible for aldosterone. Aldosterone is going to be important for maintaining salt and water balance, which you could imagine can help with blood pressure regulation. Too much aldosterone could mean that you're holding on to too much salt. That can make your blood pressure go high and make your sodium levels really high. Likewise, not enough aldosterone could make the blood pressure low and make your salt levels really low. Then in the zona fasciculata, you have your glucocorticoids, and that's things like cortisol. And cortisol is going to be really important in the stress response, the response to inflammation, in metabolism, and blood pressure regulation as well. And when somebody gets like a cortisone shot for an injury, that's what this is. Glucocorticoids. It's cortisol at the end of the day is really that physiologic, the chemical that's going to have that physiologic effect. And so very important for those things. Too much of those can cause issues, as well as not enough of that, which we'll talk about in the shortly. And then in the zona reticularis, you can think about that as the androgens. So that's things like dehydroepiandrosterone, and that's going to play an important role in sexual development and secondary sexual characteristics, sex drive, in sort of concert with the gonads, which we'll also talk about later. So this creates another one of these axes that we call the hypothalamic pituitary adrenal, or HPA axis. And to refresh, you have, here they write CRF, but CRH would be fine as well. And that's the releasing hormone that's going to act on the anterior pituitary, making the anterior pituitary secrete ACTH, which is going to act on the adrenal gland to produce cortisol. That cortisol is going to go and have physiologic effect, and then as it goes up, it will have a negative feedback to the pituitary and the hypothalamus to reduce the production of that cortisol. When cortisol levels are too high, sometimes it's the medical system. For example, we are prescribing very high levels of steroids to treat inflammatory disorders. Sometimes it's from tumors that are secreting things like ACTH that can act on the pituitary to create sort of unchecked stimulation of the adrenal gland. And then you can have hypocortisolism, which is low cortisol levels. And there's primary forms of this, which you may have heard of Addison's disease, which is oftentimes an autoimmune issue, some damage to the adrenal gland that's making it not function properly and causing low cortisol levels. Other things can do this, like infection, like tuberculosis. Cancer can sort of play a role in this. And then you could also have secondary hypocortisolism, which could be from certain medications. For example, if that person who was being treated with steroids for a long time actually stopped their steroids, their adrenal gland might not recover fast enough, and there might be sort of a secondary um, deficiency of cortisol because your own adrenal glands are having trouble playing catch up because you were getting exogenous steroids for so long. And then tumors can also do this, as well as sometimes if the pituitary gland is removed for some reason, like a tumor, um, and making it so that the sort of middle part of this HPA axis is non-existent, and so then we'll sometimes need to bypass that by just providing exogenous cortisol via medications. Now, the symptoms that folks will have with too much or too little cortisol can be very widespread. And a couple of important things I think to highlight as far as what should set off what should raise some flags in your head. The high levels of cortisol will typically cause weight gain. It will cause redistribution of fat, so you get sort of this buffalo hump, a bump on the upper back. You can get striae, which are evidence of thinning of the skin, sort of purple lines along tissue. You can get menstrual irregularities, acne, and something called hirsutism, which is sort of a masculinizing feature that can be found in women where they begin growing some facial hair, typically along the sort of jawline. And high levels of cortisol can also cause holding on to more fluid, so you can get peripheral edema and swelling. It can affect libido. It can affect cognition, can cause depression, make it difficult to sleep. And it can also, over the long term, damage the bones and decrease bone density, can affect the cholesterol levels, can affect sugar levels. It can affect blood pressure, and can overall decrease the immune function. And likewise, or on the opposite side, very low levels of cortisol can cause some of the opposite of these things, like very low blood pressures, body hair loss, weight loss, muscle and joint weakness, upset stomach, low blood sugars. This can also cause depression and changes in libido, typically a loss of sex drive or erectile dysfunction, and can also cause menstrual irregularities in females. And in particularly with Addison's disease, you may see some darkening of the skin, and that's a very specific finding related to Addison's disease as opposed to other forms of low cortisol levels. So that brings us to the pancreas. In the pancreas, the main hormones that we're going to be concerned with are the insulin and the glucagon. Together, they're going to help us regulate blood sugar levels. And this one is also not regulated by the pituitary, so this one doesn't have that axis that we were just talking about. But the most basic way to think about it is if you look on the right side of this picture, when you eat, it increases the blood sugar, and then you have these beta cells in the pancreas that are going to release insulin. Insulin's job is to take blood sugar from the blood and bring it into the cells, in this case, the adipose cells. And that will decrease the blood sugar. Now, you don't want to decrease it too much, so when it gets to a certain point, the pancreatic alpha cells will then release glucagon. And glucagon is going to be a counter-regulatory hormone that will go to the liver and break down glycogen, and that glycogen will break down into glucose molecules that you can then get back into the bloodstream to use for energy. And then you'll notice on the left side of the picture, you can also see that exercise will decrease blood sugar, and exercise will pull sugar out of the bloodstream as well. So you can sort of enter the pathway at that point and sort of induce that glucagon function from the alpha cells. And you can imagine that if the insulin or the glucagon are functioning inappropriately, that you can get dysfunction. So now here's a slightly more complicated diagram. But what you're seeing is, if you start with the top there, A high blood glucose level should make the beta cells create insulin. Insulin should make you take up glucose and use it and store it, which should lower the blood glucose, act on the alpha cell to create glucagon. Glucagon goes back and acts on, again, the liver or other areas to try to get new glucose molecules into the blood. And then what you see is that if there's a deficiency of insulin, for example, in diabetes, then it's going to make it hard for you to get sugar from the blood into the cells. It's going to decrease the glucose utilization, and it's going to make you think that you need to work at getting glucose from other sources, like the fat and the proteins. So that's called lipolysis and proteolysis, which are going to break down fats and proteins to try to get sugar into the blood. Likewise, if there's a excessive glucagon response, then you're going to get decreased synthesis of glycogen, which is the storage molecule for sugar, in the liver, and then you in the muscle, and then you have ketogenesis, so you're creating ketones, which you can use for energy, but can also in high quantities, can have some dangerous impacts. And then glycogenolysis, breaking down glycogen, and you're getting gluconeogenesis, making glucose molecules from things like lactate. And when you think about other areas where this can be dysfunctional, you could have something like a glucagonoma, which is a tumor of a glucagon secreting part of the pancreas, and that could primarily cause you to do too much of making new sugar. Certain medications can make sugars go up. Again, as we talked about, certain steroid medicines, for example, will make the sugars go up. And then the stress response, the fight or flight, that will also try to activate a lot of mechanisms that will get sugar into the blood. And then you could also have mechanisms that lead to hypoglycemia or low sugars, and that would be things like insulinomas. So if you had a tumor of a part of the pancreas that creates insulin, then that could secrete insulin without any regulation and continuously pull sugar out of the blood against a counter-regulatory mechanism, and the very low levels of sugar that would normally trigger the alpha cells to make glucagon are insufficient because you have so much of this insulin getting kicked out by the beta cells, and it can cause low sugars. Likewise, things like medications like insulin, if you're taking a lot of exogenous insulin or other anti-diabetes medicines, that can make sugars go low. And then fasting, not eating for a long period of time or exercise, especially if those are done together, can cause really low sugar levels and lead to activation of that glucagon portion of the pathway, ketogenesis, and glycogenolysis and gluconeogenesis. So now to talk about the gonads, we'll start with the testes, and we'll start by saying that the testes are basically producing sperm and testosterone. And the testosterone is going to be important for development and maintenance of the male reproductive structures and sexual functions and characteristics, things like more lean muscularity, facial and body hair, deeper voice with a wider larynx. And at the bottom, you'll see another one of these negative feedback loops where you have the GnRH from the hypothalamus stimulating the anterior pituitary to make LH and FSH, which are luteinizing and follicle stimulating hormone. The LH will act on the Leydig cells of the testes, and the FSH will act on the Sertoli cells. The Sertoli cells facilitate spermatogenesis, making sperm cells, and then we'll also create something called inhibin, which you don't need to know about, but will act back on the anterior pituitary to turn down the dial. And then the Leydig cells will produce testosterone, which then act on the anterior pituitary and the hypothalamus, again, to turn down and regulate that negative feedback loop. When there are low testosterone levels, in this case, hypogonadism, you can have a delayed puberty. It can cause depression, infertility, erectile dysfunction, body and hair loss. And then hypergonadism, or too much testosterone in this case, can cause precocious puberty. So these are kids who are developing too early with sexual characteristics. You can have increased face or body hair growth and more of an increased libido. And the important thing to note here as well is that there are both estrogen and testosterone at play in males and females. So also just note that males can also end up with too much estrogen, which can cause gynecomastia or male sort of breast development, feminization of their physical features, impotence, and a loss of libido. And in our Tanner staging that you see here, this is basically male sexual development somewhere around 8 to 15 years old. People will start going from stage 1 through these various stages of sexual development of puberty, and then somewhere around 13 to 18, people will generally have finished and attained stage 5 of their what's called a Tanner stage, and that's would be their adult genitalia as far as size, function, the hair development, and then that will bring us to the ovaries, which are producing estrogen and progesterone, and are going to be very important for the menstrual cycle regulation as well as development of female sexual characteristics and function. It'll be really important for breast development, and then will be also relevant for fat distribution and leading to some of the more rounder features found in females typically. And when there is dysfunction, you can see issues with ovarian insufficiency. So this is females who are basically running out of egg function earlier in life than expected, other menstrual disorders, and hot flashes. And then hypergonadism, and too much estrogen in this case, can also cause menstrual irregularities, can cause enlargement of the breast or the uterus tissue, which over time, if there's a lot of stimulation of those tissues, sometimes can increase the risk for cancers of those tissues. And then likewise, females also have a certain amount of testosterone, and so hyperandrogenism, high male hormone levels, can cause masculinization and hirsutism. So here's a picture of some of that sort of fine hair growth on the jawline to the chin of this patient on the right. And in the picture on the left, you see the menstrual cycle, which you're going to learn much more in depth at another time, but essentially just noting that the green FSH and the red LH, you can see that they're going to sort of have this relatively stable level during the follicular phase, and then you'll see sort of this spike, or what's called the LH surge, at the time of ovulation that will correlate with typically the highest estrogen levels, and then you end up with declining estrogen levels, and progesterone dominates what's called the luteal phase. And this is how the menstrual cycle typically is going to carry out over the period of 28 or so days, and will be very relevant for a lot of your future patients and athletes, but you'll go more into depth with that with other lectures. And here's the female Tanner staging, same idea, moving from early pre-adolescent development through to that Tanner stage 5 of mature adult physical characteristics by somewhere around age 13 to 18. And here we have that negative feedback loop. On the left, you can see the left side showing the LH and FSH going to the testicle to produce testosterone, which feeds back to the anterior pituitary and the hypothalamus, whereas the GnRH stimulates the anterior pituitary going to LH and FSH towards the ovary on the right side. Ovary will produce estrogen and progesterone, feeding back to the anterior pituitary and the hypothalamus. And I will just make a note here that there's several different etiologies for the dysfunction, with some of these really complicated systems that have a complicated interplay of testosterone and estrogen, with differential diagnoses, management that are going to change drastically based on the context, phase of life, stage of development. So we won't get too into that today, but more so just being able to pick up on some general themes that we'll talk more about in class. And so with that, feel free to send me an email if you have any questions. I'm always happy to chat further about these things, and we'll be discussing a few cases in class when I come by next week.